It's an honor to introduce to you Professor Bruce Wampold. Bruce Wampold was trained as a mathematics at the University of Washington before earning his PhD in counseling psychology at the University of California in Santa Barbara. His work involves understanding psychotherapy from empirical, historical, and anthropological perspectives, which has led to the development of a contextual model of psychotherapy. His work is summarized in the book, The Great Psychotherapy Debate, The Evidence of What Makes Psychotherapy Work. He is a fellow of the American Psychological Association and a diplomate in counseling psychology at the American Board of Professional Psychology. In 2007, he received a Distinguished Professional Contribution to Applied Research Award from the American Psychological Association. He is also an honorary doctor in the social sciences at Stockholm University. The floor is yours.
Well, I'm very pleased to be here in this wonderful city with beautiful weather. I know it's like this all the time, right? Sunny and crisp, warm. So thank you for the invitation to talk about psychotherapy. I'm retired from my professor position, so any chance to give a lecture is always appreciated. So the challenge today was to talk about the future of psychotherapy and mental health treatment. And of course, it's always difficult to predict the future, but it's a really important topic because we're at a crossroads. So let's just review a little bit about the history, and not just simply the history of psychotherapy, but history of humans. So 7 million years ago, our ancestors started to walk upright. So that's a long time ago, of course. 1 million years ago, we developed language and communication. And clearly, the human was evolved to use these languages. Many species had proto-languages, and humans perfected this in various ways. Evidence that this is an evolutionary process is that different civilizations developed different languages. So very different tonal languages from phonetic languages and so forth. 125,000 years ago, a tremendous event in human history was using controlled fire primarily for cooking, but it also brought people together in community. So it was a social event as well as a technological event. 12,000 years ago, and which was, according to many anthropologists and historians, a seminal event, was agriculture. So a evolution away from hunting and gathering to raising crops nearby communities. 5,000 years ago, written language. Now, the evolution of language to communicate was pretty natural for humans. Written language was purely a human invention. It was difficult to do. There was no agreement about how you spell words or how you might punctuate and use grammar. And it took centuries for this to become standardized. 2,000 years ago, or a little more, Christianity. So the evolution from multiple gods to one God over 5,000 years ago, but Christianity predominant, one of three predominant religions 2,000 years ago. And then we have only 120 years ago, psychotherapy. This is a recent invention, and it's not entirely clear whether it was a natural evolution or just something that Freud and others thought would be a good way to treat mental illness. So let's talk about psychotherapy events. I won't go into detail, but you can see I kind of put the origins of psychotherapy in Descartes' dualism, because until the mind-body dualism, mental illness and physical illness were not distinct. The same practitioners, same processes, different depending on how the civilizations discussed it. But clearly, with the beginning of Descartes, we could think of psychological distress as something distinct from physical distress. And then you look at kind of the seminal events in psychotherapy, and it was only in the 1950s that in the United States and many other countries was a requirement to show that various medical procedures were actually effective. So the randomized clinical design as a way to test effectiveness is a recent occurrence. So I bring this up because we want to put psychotherapy in the context as this recent invention. We have an idea about how it works, but we really don't know. So I like to think about how psychotherapy could work. We sit in a room. The modal process is 50 minutes a week, and talk about the patient's life, maybe assign some homework and different activities, but primarily it's this 50 minutes. How can talking to a person in a room result in effects? It's quite amazing when you think about it. So what do we know about psychotherapy? And I think we all know this, and hopefully we all believe that psychotherapy is effective. And, you know, the research is pretty convincing. It's demonstrated in randomized clinical trials comparing psychotherapy to waitlist controls, for instance, so no treatment. Psychotherapy for no treatment. The effects are relatively large. It's also been demonstrated in practice. So practicing psychotherapists get effects that are comparable to randomized clinical trials. And this, frankly, is quite amazing, really, because in clinical trials, the patients are screened, severe comorbidity is ruled out, the therapists get special training, they're selected for their expertise and so forth, and they get this wonderful supervision. In many clinical trials, you get 1 hour of supervision for every hour of therapy delivered, quite a luxury. Yet, in practice, the effects are comparable. Psychotherapy is as effective as medications for most mental disorders. So for anxiety and depression, particularly, but others as well. Psychotherapy is longer lasting. When you withdraw medication, the relapse rate is relatively large, whereas if patients for the same disorder receive psychotherapy, the effects are longer lasting. Of course, psychotherapy has fewer side effects than, let's say, antidepressant medication. And psychotherapy is less resistant to additional courses. So the second or third or fourth time somebody receives psychotherapy is just as effective as the first administration. Not true in medication. So as you heard, I was trained in mathematics, so I like numbers. So the NNT of psychotherapy is 3. What does this mean? Well, NNT is the number needed to treat. It's the kind of statistic that's the cheerleader for medicine. So how many patients have to receive a particular medication or procedure in order to get one additional success? Okay. So the NNT of psychotherapy is 3. That means every 3 patients treated, we have one who experiences a benefit that's greater than they would have received had they not received psychotherapy. Well, in a sense, that sounds kind of depressing, right? So 2 out of the 3 patients we see would have comparable outcome staying home. Well, again, psychotherapy is effective as medication for mental disorders. And if you look up the NNTs for most medical practice, you'll see that they're quite large, actually. So you look at cardiology, open heart surgery, removing blockages, coronary blockages, NNTs of 15 or 20, as well as NNTs that are very high for side effects. Okay, so psychotherapy does all right, but clearly there's a room for improvement. So what makes psychotherapy work? Well, I'm talking about the future of psychotherapy, so tomorrow I'll talk a little more about what are the actual mechanisms that make psychotherapy work. But what do we know about mental disorders and their treatment? And here I'm going to talk about statistics primarily from the United States and different epidemiological studies, but they're not too different in Western Europe. So it looks like only between 30 and 40% of those with a psychiatric diagnosis actually receive treatment. Okay, and this is in the last 12 months. So if you have an incidence of mental illness, only 30 to 40% will receive any mental health treatment. That seems to be increasing, not rapidly, but a bit. Okay. Who treats patients? And again, this is from the United States, but it's interesting. So psychiatrists in the United States primarily are biologically based. So it's very, very rare anyone receives psychotherapy from a psychiatrist in the United States. But about 12% of those patients who are treated receive treatment from a psychiatrist. So non-psychiatrist mental health specialists, about 16% of those treated receive this treatment, primarily psychotherapy. So this is where we see people suffering, receiving psychotherapy. But now if you think about it, that's 16% of the 40% who are getting treatment. So 6% of those suffering from mental illness or distressed psychiatric diagnosis actually receive psychotherapy. So, of course, as psychotherapists and students of psychotherapy, we think about this as the most important and the most helpful treatment, but only about 6% of those suffering actually get or take advantage of psychotherapy. In many communities in the United States, people don't want to go to psychotherapy. It's a cultural practice accepted by primarily educated people, knowledgeable of different treatments. So there are many communities in which psychotherapy is really not an accepted practice. And of course, around the world, in many countries, psychotherapy isn't even a practice that would be considered. It's not available. It's not familiar. again, this points to the fact that psychotherapy is a cultural practice. So in the United States, the most mental, let's put it this way, the treatment that most patients receive for mental or psychiatric disorders is from a primary care physician. So the physician you see for common colds, for the flu, for minor traumas and so forth, is also the practitioner that treats mental disorders primarily with medication. In the United States, other human service providers, social work, nurse practitioners provide mental health service, and then complementary and alternative providers as well. And I'll talk a bit more about that. So let's look at some trends in American psychotherapy. The payment for providing services really has been stagnant for probably 2 decades. So particularly if the psychotherapist is paid through insurance, through some government program, or through business and industry directly, the reimbursement rates have been pretty stagnant and now are quite low. Around the world, as well as in the United States, mandating shorter treatments. So often in the United States, if your patient's been diagnosed with major depressive disorders, the payer might say you're limited to 6 sessions. Okay. Another trend is that psychologists, psychotherapists, which I am, are relatively expensive. You know, we spend more years getting training. We have a professional organization, the American Psychological Association, that lobbies to benefit our payment and so forth. Well, it's cheaper to hire licensed professional counselors, which is like a master's degree therapist as opposed to a doctoral level psychologist in the United States, as well as mental health technicians. Now, this is a consequence of manualized evidence-based treatments, because if there's a manual you can follow for 6-session treatment for major depressive disorder, and it's following the manual, then you don't need well-trained 6 years of training to be a licensed psychologist in the United States when you can teach a technician to use a manual. Increasingly around the world, the type of treatment is mandated. So in many countries, not only is the number of sessions limited, but the treatment delivered is mandated. So in the National Health Service in England, for instance, cognitive behavioral therapy is the treatment that's offered to everybody. It appears in the guidelines, the NICE guidelines, and all of the therapists need to be trained and deliver cognitive behavioral treatment. Another trend around the world is a shortage of therapists. Okay, in the United States, it's very difficult to find a therapist who has room in their practice to see you. So you can, often in the United States, you belong to a particular insurance company. They have a panel of therapists. They recommend one of their therapists. Only the wait list is 6 to 12 months. Nobody has room in their practice. So there's this shortage of therapists. All of this could be seen as a consequence of incorporating psychotherapy in the medical practice of various countries. And we could go through that in some detail, but it's this idea that psychotherapy is a medical practice has been tremendously important for our development because we get paid through these medical systems. But it's also really changed the way we do psychotherapy. Okay, back to this idea about as we're psychotherapists or psychotherapists in training, and we believe that seeing a psychotherapist is an important event in people's lives. And many people say whether you're suffering from a diagnosis, a psychiatric disorder, or not, this is a way to improve your quality of life. But it's not the only way people change, okay? John Norcross has done several studies and summarized the data. People change by reading a book. So how to make your life better actually produces large effects. Internet CBT. So there are many programs developed, several recognizable ones from Sweden at Linköping University. And the research seems to show that internet CBT, particularly for anxiety disorders, but also for other disorders, is as effective as face-to-face supervision. So there's some problems with the research because the people in these trials are ones who think that internet CBT is a viable treatment. There's also internet psychodynamic therapy, which turns out to be as effective as internet CBT. Self-help groups, okay. Alternative methods, acupuncture, meditation, a number of different methods. And we have to think that for some people, these methods are just as effective. What about psychics, religious figures, traditional healing practices in many countries and indigenous communities, bartenders, friends, intrinsic methods, thinking about how you can change on your own. I put psychics in red because Scott Miller and colleagues did a survey, and it turns out many people visit psychics, talk to your dead relatives in another world. And it turns out that in the United States, people pay for psychics as much as they do for psychotherapy, okay? So, of course, we don't get government reimbursement for going to see a psychic. But what's interesting is that well, we won't call them patients, but the individuals who see psychics actually experience change on the order of magnitude that they experience with psychotherapy. So again, this idea that psychotherapy is some special treatment that is needed for the treatment of mental disorders, probably not true. Or I should say maybe demonstrably not true. Placebos. There's lots of work that taking a placebo for a mental disorder will result in significant change. In fact, Irving Kirsch, in several really brilliant meta-analyses have shown that 90, 95%, or maybe even 100%, except for severely depressed people, antidepressants are a placebo effect. So the psychiatrist and the primary care physicians prescribing antidepressants really are extensively prescribing placebos. We did a study in which we looked at the differences in effects among psychiatrists giving antidepressants. And it was a double-blind study, so half the patients received placebos, half antidepressants. And what we found out is the most effective psychiatrists got larger effects giving placebos than the poor psychiatrists got giving active medication. So much of the effects of treatments for mental disorder are placebos. I know that's kind of, well, we just give placebos, but placebos are quite amazing, and I'll talk in detail tomorrow about why that is. So, just to change the subject quite dramatically, I want to talk a little bit about the history of computing, and I'll make the point why this is relevant. So, 1821, many people credit to the beginning of computing machines. This was Babbage's steam-driven calculating machine. It was quite an elaborate machine, and creative and quite innovative. Ada Lovelace, Lord Byron, the poet's daughter, wrote the first computer program. 1931 differential analyzer. Alan Turing, mainly a theorist rather than actually development of computer, had this challenge that the computing machine could be differentiated from a human. So the Turing test is, if you interact with a computer, could you be indifferent about whether it's a computer or a human? And that's an interesting idea. And they still apply the Turing test to various endeavors. Hewlett-Packard Company, first kind of mainframe computer in 1945. UNIVAC was probably the first bona fide mainframe computer. First computer language, the computer chip. So until that time, they were all first tubes and then transistors, but then a computer chip. Internet, of course, 1973. To many of you, this is a long time ago. To some of us, it's just halfway through our lives. Apple computers, Bill Gates, Microsoft, and personal computers. Google, of course, it's a verb now. You Google something. Facebook. In 2004, pretty much, computer was as skilled as a chess master in doing chess. And actually, the recent competition between Magnus Carlsen and Niemann from the United States, Carlsen accused him of cheating by getting information from a computer about what would be the best move. So here's computers doing a human endeavor as effectively or more effectively than a human. The reason why this is important is that computers developed at the same time frame as psychotherapy. Okay, psychotherapy, a particularly human endeavor, right? Sitting in a room face to face with a human, and on this alternative track, we had the development of the computer. 2022, we do most everything on computers, right? We often have chats with some computer site. We want to buy a product, and you don't actually know, am I interacting with a human or am I interacting with a bot? And it's very difficult to tell. I try to ask particular questions, but they're pretty good. So let's talk about what happens at each of these transitions. language, written language. I probably should have put in that timeline the printing press, because that was a seminal event in human history. But at each transition, there's this fear. We're going down the wrong road. This is the end of human civilization as we know it. So here's Carl Breidenbau, president of the American Historical Association. Again, in 1962, in his address, presidential address to the American Historical Association, he said, human existence, we're going through this god-awful great mutation. Okay. We are now suffering something like human amnesia. And he lamented about the decline in reading. People are no longer reading like they used to. And we're also quite distanced from nature. And he said these ugly Kodak boxes, right, cameras, and transistor radios. So I call this the Carl effect, because at each stage of development, we say we're going to damnation because of some technological advance. Well, in terms of psychotherapy, we'll see. Many times I feel like saying, yes, Carl, you're right, because things are changing. Well, biggest change or most apparent change is we now do much psychotherapy not in a room face-to-face, but we do it over some kind of a video platform, Zoom or some other video platform. And this was a necessity because of COVID. Well, like working at home, we're probably not going back to giving exclusively face-to-face psychotherapy. Okay. United States, many companies want their employees to come back, and they go, we're not coming back. We don't even live where our business is anymore. We've moved. We don't want to drive. The distance is too great. Well, same in psychotherapy. We're not going back. Many patients prefer video. There's no disruption of life. You don't have to find transportation to a therapist's office. There's a stigma. I don't have to walk into a waiting room with crazy people. I'm not like them, right? I don't want to be seen in a mental health clinician's office. It's convenient, and many patients report they're more self-disclosing. There's something a little less personal in a video conference. Again, it's not what's true, it's what we perceive to be true. So we're not going back. Maybe somewhat, but not entirely. Well, the Carls out there would say, you can't do effective psychotherapy on a video platform. It's difficult to form an alliance. You don't see the nonverbal behavior in the same way. It's not that human, close, proximal distance that's important for human connection. Okay. But, you know, it's a modern world. Many people do much of their social relationships online. So again, we think, oh, these young people, they're on Facebook, they're on social media, TikTok. This is the way they communicate with each other. Social relationships are changing the way. So here's a surprise. Video psychotherapy is as effective as face-to-face psychotherapy. So those of us who are Carls, we're going to say it's not as good. You can't do it this way. It's the end of how we do psychotherapy. but it works. Okay, several meta-analyses. We've done a large-scale study of patients before COVID, after COVID, matched on a number of variables, and the benefits of video delivered psychotherapy are about equal to face-to-face. So, what happens? Well, in the United States, we have these huge companies, Talkspace and BetterHelp. So you don't have to go to, well, you don't go to a phone book anymore to look for a therapist in your community, but you go to Google, right? And you look up therapists. Now, you just join Talkspace or BetterHelp, and you can find a therapist anywhere in the United States to help you, okay? So you don't have to look for somebody in your community who's available. And it may be that you live in a small community, there are no therapists, or all the therapists are extremely busy. I'll just get online and find a therapist somewhere. By the way, these are billion-dollar companies. Okay, this is not, as we say, small potatoes. Okay. And the problem these companies are having, finding therapists. So as a licensed clinician, I get an email probably once a month asking, hey, why don't you come work for us? And they don't say it's working for Talkspace or BetterHelp. Usually, this one's BetterHelp, but they usually just say, we're looking for therapists. This is a great way to have a practice. There are some advantages for therapists because they don't have to leave home. They can see patients anywhere, so they don't have to worry about finding patients. So, and third advantage is you can work anytime you want. So you can put open slots in your calendar, and potential patients or continuing patients pick what slots you have open. So if you want to work 3 hours a week, you can do that. Have 3 particular slots. Interesting, BetterHelp spent over $100 million last year in advertising. So the reason I want to emphasize this is big business. So we're no longer psychotherapy individual practitioners kind of in business for ourselves, or in a small group practice often in the United States with maybe 5 to 10 psychotherapists in the same practice. Now we're part of a billion-dollar company making money from us. By the way, therapists hate BetterHelp and Talkspace. There's a reason why they can't find therapists. The remuneration is low, so they'll each take about half of your income or half of your fee, so you receive about half, okay? It's convenient. There's no insurance form. There's no paperwork. You just get online, see your patient, and be reimbursed. Well, what about mental health apps? I can't find a therapist. The stigma's too great. I don't want to see. That's only for crazy people. I don't want to see, we say, the vernacular, I don't want to get my head shrunk, right, and go to a shrink. It's for crazy people and others like that. So, how do you get help? Well, again, John Norcross studied bibliotherapy. Most people don't get books anymore, they get a mental health app. So in 2017, there were more than 10,000 mental health apps for your phone. And you can go to your Google Play or your Apple Store and put in mental health, and you'll get a listing of these apps, okay? In 2022, in the United States, over $500 million was spent on the apps. Yeah. And I should give you, I didn't put a slide for this, But they call it the click rate. How many people, once they buy an app and download it on their phone, actually use it? And it's pretty low. Okay, it ranges, still using it a week later is about 20%. Okay, but if the 20% respond and do well, that's an improvement in mental health. So there's an app for everything, of course, on your phone: diet, physical activity, mind training, sleep. So why not mental health? Well, part of the problem is there's no oversight to these mental health apps. We don't know if they're effective. They're for-profit businesses using the high prevalence of mental disorders to make money. The data collected on mental health apps in the United States are not regulated by our health security law, HIPAA, okay? So, if you see a mental health professional or a physician, that information is strictly restricted in various ways. It's not true for mental health apps. So the information collected could be shared. So here's an article from the New York Times: how to find a mental health app that works for you. Okay, and they go through how to do this. It's not that easy. You don't really have any good data about effectiveness. Of course, you have ratings. This is a 4-star. It was great. The service was good. The dinner was delicious. I really liked the ambient. Oh, that's restaurants. The ratings are similar to restaurants. Okay, let's talk about electronic solutions for mental health problems. Well, how can we use electronic applications in face-to-face psychotherapy? Well, we can do electronic scheduling, record keeping, billing, email, and many apps for chatting with your patients. So this is the traditional psychotherapy model, in a sense, augmented by electronic solutions. Not very interesting. They're relatively helpful, of course, in the United States, particularly for billing and scheduling and record keeping. But I would say probably not much choral reaction to this. Okay, it's still face-to-face supervision. I don't think any of us really have too much difficulty thinking about using an electronic platform for scheduling. Then we have the electronically delivered face-to-face psychotherapy. This is the BetterHelp and Talkspace. It's as effective, but it's problematic in the idea that these large for-profit companies are kind of managing how we do psychotherapy. Then we have computer-assisted therapy. And internet CBT has been around for 15 or 20 years probably. So this is not something too remarkable. Computer-assisted therapy, it's effective. Randomized clinical trials pretty established that getting some kind of treatment, usually CBT because it's easier to implement in a internet-based format. But what about the alliance? We know alliance is important in psychotherapy. Where's the alliance in internet CBT? So we'll talk a little bit about that today. And then there's apps with no therapist in the background. Well, I should mention in the internet CBT, most applications, there is a therapist in the background. So the therapist might look at the data and progress, write notes to the patient can write notes to the therapist, different degrees of therapist in the background involvement. Okay. And again, this is evolving, so the therapist in the background is increasingly a bot, not an actual therapist. And then there's the apps with no therapist in the background. So you have difficulty with depression, well, let's do anxiety. And your mental health app will educate you, so you get psychoeducation about anxiety. You might get some exercises to do, some exposures to do, but all without any interaction with a professional. Then we have, and this is my biggest Carl for me personally, is precision mental health. And the idea of precision mental health comes from precision medicine. And in precision medicine, you have some type of cancer. Well, there's a standard chemotherapy for this particular kind of cancer. Precision mental health measures your genome. It knows your physiology to a precise degree, and you get a therapeutic tailored to your particular body. So it's a precision treatment based on your particular genetic makeup and physiology. So in mental health, we have this attempts to do precision medicine. So we can match the patient to the therapist. We know that some patients seem to hit it off better with some therapists. There's not much data to support that, but it's a conception. So the idea is we're going to match patients to the therapist based on their diagnosis. So some therapists, according to this model, may be better treating borderline personality disorder, for instance. So if you have a diagnosis of borderline personality disorder, then you get matched with a therapist who's more effective with that particular diagnosis. But also match then on personality. What kind of personality, what kind of history do you have? And there's attempts to do this in a way. Well, part of the problem is there just aren't enough therapists, so it's really hard to match. I just want a therapist who can see me within a month. If I have to wait for one who's matched precisely for me, it might be a longer waiting list. But we also want make attempts in precision mental health to match the patient to the treatment, and not just the type of psychotherapy. Okay, we could do an assessment and say you're going to respond more quickly to CBT than you would to psychodynamic therapy, for instance. That would be to the type of psychotherapy. But many of the medical organizations in the United States are matching you to the type of service you need. So some kind of step care where we might say, well, patients like you respond quite well to a mental health app, so we recommend this particular app. And you can't see a clinician because we've determined that this particular treatment is most effective at your stage, your history, your personality, and so forth. I show the picture of the supermarket because when I go to the supermarket, I want to be able to pick my own vegetables, right? I don't want to say what's most healthy for me is celery and spinach because I want cauliflower and carrots. Okay. Well, precision mental health doesn't take into account patient preference. Okay, I've had this discussion with several of the organizations that do precision mental health in the United States. And I say, what about patient choice? This is a patient who doesn't want an app, wants to talk to a person, doesn't want medication. Well, no, we know what's best for them. So there is a danger to this in my estimation. But it could be, I'm Carl Bridenbaugh. That's the end of the world, precision mental health. So just an article by Len Bigman, who's been kind of on the forefront for many decades in measurement-based care and using various assessments to guide mental health treatment. And he talks about the 50-year journey from randomized experiments to artificial intelligence and precision mental health. So, if we talk about electronic applications, we really need to talk about not what's happening, but what needs. What do they actually address? So here's my list of what we can address with various electronic and software solutions. Of course, the first thing we want to address with any kind of intervention is, does it actually work to reduce distress? Okay. We also want to address with electronic applications access. So the biggest problem in mental health in the United States is actually access to care, either a psychotherapist or a psychiatrist. So this is why most psychiatric medications are delivered by primary care physicians, because you can't get access to a specialist mental health provider. Well, how can we use electronic solutions for therapist education? So I look in the audience, I know some of you are students. Think about your training. Is there some application, electronic application that aids in your training? Well, you might get video tapes of your sessions to use in supervision. That's hardly a modern software solution. I put in that therapist education, training, and improvement measurement-based care. So I didn't talk about it much today, but we know measuring the progress of our patients and providing that information to the therapist makes a difference. And most of that's done electronically now. And again, then, even if you're in traditional psychotherapy practice, software solutions can provide assistance to the therapist. So the question is, are we progressing? So are these software solutions that are available actually resulting in better mental health? Well, I'll give you a couple of examples here. This is Benedict Carey. He was the mental health journalist for the New York Times for, I think, 3 decades or more. Okay, I had several interactions with Ben about different articles he was writing. And he said, when I started as a journalist in mental health, I had this hope that throughout my career, I would see breakthroughs so that there were dramatically more effective mental health treatments. And what he basically says in his farewell address, there isn't. The prevalence of mental disorders, if anything, is increasing, and treatment effectiveness is stagnant. So we're not really progressing in that way. Even more distressing is Thomas Insel, psychiatrist who was the director of the National Institute of Mental Health in the United States, directed the agency to focus on biomarkers, neuroscience, genetics, and medication treatments for mental disorders. Billions of dollars were spent on these endeavors under his leadership. Okay, the funding for psychotherapy and kind of humanistic kind of treatments in the sense that we're meeting face-to-face with our patients disappeared. We couldn't get funding for research. Well, at the end of his tenure at the NIMH, he wrote a book lamenting the fact that we wasted billions of dollars because we didn't progress. There's no major breakthrough. We don't have biomarkers for mental illness that lead to early intervention to prevent, let's say, severe mental illness like psychosis. Doesn't exist. So, at the broadest level, are electronic applications helping kind of this technology? I would say no. Nearly all electronic applications and electronic solutions are untested. The effectiveness is unknown. Okay. But I want to look at some promising examples. And here I have a conflict of interest because these are different endeavors which I'm involved with. And the reason I use these is I have criteria for which companies I will do some work with. First, the company has to be based on current evidence. Is this a legitimate endeavor which you could say the architecture is based on what we know about mental health and its treatment? Does it address one of those particular issues we talked about? Improvement, access, and so forth. Training is another one. And are the companies willing to collect data on their effectiveness and examine evidence? If they meet those criteria, then I'm willing to be involved. So here's some examples. This is Listen. And it's a company actually founded in part by my former student, Zach Immel, that uses natural language processing to analyze psychotherapy sessions. So it records a session, creates a transcript, analyzes us with the latest artificial intelligence and machine learning by PhD computer scientists in natural language processing, and then gives the therapist feedback about empathy, about the degree that they're following treatment protocol. For instance, has been applied for motivational interviewing. Are you adhering to the principles of motivational interviewing? What's interesting is many computer scientists interested in this natural language processing are very eager to work in the psychotherapy space because they think this is an application that actually has a benefit for society. You know, they're paid astronomical wages to work for businesses, for-profit businesses on different processing of natural language, but they want to work in the mental health space. So it's exciting what you can do with this area. Peer Collective is providing online, like psychotherapy, interaction with a peer counselor. So somebody not with a professional degree. So you'd say, well, How is this scientifically based? Well, first of all, we have evidence that peer counseling, getting support and empathy, and even some advice from a peer counselor is very effective and actually preferred by many mental health patients for a variety of reasons. But how this is scientifically based is, I've worked with them to screen peer counselors to be able to give them a challenge test and pick those that are most effective, and then use some deliberate practice technology to train the peer counselors. So it is an electronic application, not only in the selection of the, or the provision of the peer counseling, but also in the delivery and the training of the peer counselors. Formulator is a Finnish company working on electronic software solutions for case conceptualization. And the idea is that the patient interacts with this system and gets a formulation about their difficulties, which is useful for the patient, but also for the therapist to get an idea of the patient prior to treatment. MioMind is a company that produces psychotherapy sessions that patients can listen to. So instead of actually going to a therapist, you can listen to a therapist giving therapy to somebody with a problem like yours, a person like you, and patients or people in distress, we shouldn't call them patients, because many of these people don't want to see a mental health professional, but find this particularly useful. And the sessions have homework, so they're things for the individual listening to do. So it's kind of vicarious therapy, if you think about Albert Bandura. I'll skip this one. This is one I'm most involved in. This is an electronic platform for learning therapy skills. So you get a video of a particularly difficult interaction, and you respond as if you're the therapist. And then you can watch your response, practice it again over and over, submit it to an instructor or supervisor for feedback. It follows the principles of deliberate practice. Okay, we know experts in musical performance, in athletic. What makes an expert performer? This idea of deliberate practice. Okay. So I want to talk just for 2 or 3 minutes about the alliance, because the core of us are going to go, wow, you need an interpersonal relationship. We know, and in fact, Bruce, you're the one who's produced a lot of research showing the relationship is absolutely critical to success of psychotherapy. And now you're standing before us talking about these software solutions. So, we have a lot of relationship factors. We call them different things: alliance, collaboration, goal consensus, empathy, congruence, genuineness, the real relationships, and so forth. Oh, that's a lot of relationship factors. But it turns out you can break them down to 2 primary components: the warmth of the therapist and the competence of the therapist. And actually, this applies to medicine as well. It's interesting. In the basic social science, Susan Fiske, a famous psychologist, said there are 2 universal dimensions in social cognition: warmth and competence. Okay, I'll give you just a quick example of these 2. When you're lost in a foreign city, and you don't know how to find your hotel, it's dark at night, Your phone ran out of battery, so you can't use Google Maps. You have to ask somebody. Well, you have to determine, is this somebody who's going to help me or somebody who's going to rob me of my possessions, right? So this is kind of the warmth dimension, is trust, caring, support, and you have to make the determination. And every psychotherapy patient makes this determination. This is somebody that cares for me, who has my best interest in mind. Okay, so that's the warmth. You found somebody. They're really helpful to help you find your hotel. Next, you have to determine, are they competent? And my wife and I have traveled all over the world, and we have our favorite countries where people are so helpful. Yeah, it's right over there. And we know absolutely they have no idea where they're sending you, but they have to be helpful. So you have to determine, are they competent to help you? So that's the second determination a psychotherapy patient makes. Okay, is this a caring, warm, genuine, empathic provider? And do they know what they're doing? Is there a treatment that makes sense? So, Aliyah Crum, who's done some research on this, talks about it as when your doctor gets it, that's the disease, that's the competence, and gets you, which is understanding you as an individual. And we've done some research where we factor analyzed all the relationship factors, and we get these same two factors. Patients make a determination about warmth and caring of their therapist and of whether the treatment they're being given is going to be effective. And if you think about it, on the warmth and caring side are the humanistic therapies, motivational interviewing, just talking to a warm, caring person. This is Bill Miller, who developed Motivational Interviewing's book on listening well. It's not a therapy book, it's a human relations book. And of course, cognitive therapy, more on the competence. So when people get internet cognitive behavioral therapy, they're really looking at the determination, is this a useful treatment? So it might be that they aren't really needing a warm, caring provider. They need someone in treatment. So they have a good attachment style, good social support. The program may be enough. And it turns out that in the internet treatments, there's an alliance with the therapist in the background, and there's an alliance with the program, and they measure these separately. And it's alliance with the program that's a better predictor of outcome than an alliance with the therapist. Although in this meta-analysis that Christoph Flukacher and colleagues conducted on the alliance, all the studies that had been conducted found that the alliance with internet-provided treatments was a predictor of outcome. So the alliance is not simply with a warm, caring relationship in a face-to-face situation, but it's also with the program and the provider that's in the background. So I'll skip this because it looks like I'm running out of time. So conclusions. Well, there's no going back, okay? Electronic solutions are here. We can't be our inner Carls and say, this is the end of psychotherapy. I don't want to be involved. It's our responsibility as mental health experts to guide the development of the electronic applications. So the basic question is, are the various products, the software solutions, actually solutions? Are they helping? And we need to be involved in their development and in the research on their development. So, thank you. We have time for a few questions?
I guess we have time for 2 questions.
Okay, good.
So thank you so much for your talk. It's always very strange, but at some point understandable to see how so many of these apps are untested. But I was wondering, isn't this the same for face-to-face psychotherapy in real practice? Because for many of us, when we provide therapy, I will just speak for myself, I think that's easier, we don't really have a good idea of what is our personal outcomes. Are they as good as what is happening in trials? And so my question to you is there something we can learn from the development of these apps, perhaps some of those that you're involved in, that we can apply to some of these more personalized or personal treatment settings?
Yeah, well, it's a wonderful point, isn't it? We've tested psychotherapy at a ideal level. So the clinical trials determine whether a particular treatment, cognitive behavioral treatment or psychodynamic treatment, is more effective than alternatives or no treatment. But does that apply to a particular patient in a particular situation? And I think here we have to really think we should be using some kind of measurement-based care where we're measuring our outcomes, because the point is, well taken. Without that, we really are providing an untested solution to a patient. I agree. What can we learn as a therapist from the applications? For me, the research that is most kind of impactful for me is this idea of alliance with a program. So it's not just the belief in me as a therapist. Oh, my therapist is so warm, cares for me. But has to be, I provide my patient a rational and believable and cogent treatment plan with discrete actions for achieving those goals. So for me, that's the biggest takeaway from this. And I think as we see applications increase in usage, that they're going to become more focused on actual steps for achieving. And we can do that, I think, to a greater degree, or at least keep it in mind to a greater degree in her own treatment.
Thank you.
Great. Thank you.